Over to Anu. Madam will be dealing with anterior segment examination.
So, good morning all. So, first we'll be discussing different anterior segment cases. So, I will approach to a case. So, as you know, any case we start with a detailed history, then we'll go to an examination. So, what are the different symptoms of the patient? So, you will get sudden painful loss of vision or a gradual painful loss of vision. So, sudden loss of vision, the DDs can be due to trauma, corneal ulcer, herpes zoster or interstitial keratitis. Gradual painless loss of vision can be due to corneal opacities, degenerations and dystrophies. You may also get symptoms like colored halos and frequent change of glasses in cases with keratoconus. You will also get photophobia, redness, watering, and these are different symptoms usually patient present with in corneal cases. So, first we see a case. This is a 65-year-old female presenting with a history of pain, redness and watering for 2 weeks duration and defective vision for 2 weeks. So, this is the clinical picture of the patient. So, what is the most probable diagnosis? As you all know, this is very simple. Okay, so this is a case of hypopyon corneal ulcer. So, when you get a case like this, how will you start? So, we start with the history. These are the different symptoms of the patient. So, pain, redness, photophobia, decreased vision and discharge. So, if patients comes with a history of discharge, you may ask like whether it is watery, mucopurulent or if the color has got a greenish tinge. So, you may ask the history of trauma, any contact lens wear, any drug history, exposure to contaminated water or any previous ocular surgeries. So, what are the signs you look? So, first we start with the facial symmetry and look for the proptosis or if there is any lag of thalmosis. Look for any scars of the lid. Also examine the lid, which is very important. Look for trichiasis, entropion or ectropion. So if there is any history of chronic dacrocystitis or any scar in the lacrimal sac area, you have to think of pneumococcus. And if there is any features of canaliculitis, think of actinomycetes. Okay. So if the pain, it is more than the symptoms, you may think of acanthamoeba. Of the symptoms less, the signs are more, you may think of fungal corneal ulcer. So if any history of sudden relief of pain, just think of perforation. Okay. So we are going to the proper examination of the corneal ulcer. So what all things you have to look? So you have to look the location, size, shape, margins, base, depth, the surrounding area. If there is any pigmentation, it is very important to mention that, and vascularization. So vascularization, you have to mention the quadrants, how many quadrants are involved, whether it is superficial or deep, and look for any DM folds, endothelial plaques and keratic precipitates. Look for the AC reaction, and if hypopyon, mention that also. So the location, it will give a clue. If the location is in the superior part, most probably it will be a shield ulcer, and inferior part, we have exposure keratitis. So mention the location, whether it is central, paracentral or peripheral. The shape of the ulcer is also very important. You will be seeing a dendritic ulcer in viral etiology. Ring ulcer can be in acanthamoeba. So the margins of the ulcer, examine very well because it is very important. You may get a well-defined margin in a healing or heel ulcer, ill-defined in where there is active infection or infiltration. So feathery margin will give a clue to the fungal etiology. Punched out margin, neurotropic, and overhanging margins in Murin's ulcer. So the surrounding area, that is also very important. Look for any satellite lesions, scars or edema. So hypopyon, you have to mention the surface, the color of and the height and the mobility of the hypopyon. So don't forget to examine the sclera also, which is very, very important. So this is some of the clue which help you for a diagnosis. Like any slowly progressing localized infiltration, you may think of streptococcus epidermis, hemolytic, streptococci actinomyces, like rapidly progressing, and you may think of Staph aureus, Pseudomonas neisseria, etc. So gram-positive cocci, usually they will have a separately infiltrate with distinct margin and minimum surrounding corneal edema. So gram-negative bacilli, that will have a high tissue destruction. The borders are usually ill-defined and severe surrounding reaction. So some of the organism which has got a specific pattern, like Nocardia, which has got a reed pattern, and Actinomycetes, which has also got a cracked windshield appearance. So this is also all these things will a clue to the diagnosis. Okay, so how will you write a provisional diagnosis? You have to mention the eye, like cornea ulcer, right eye or left eye, and mention the location and the grade and whether it is complicated or uncomplicated, and also mention the stage and the possible etiology. So this is the just a clue and tips to how will you evaluate a corneal ulcer case. So next, a few points, how will you differentiate infective and sterile infiltrate? This is also very important. Sometimes you get infiltrate which is sterile. Okay, so that is usually in peripheral ulcerative keratitis. So you should also differentiate these features, and you may also get a question like how will you differentiate this conjunctival and circumcorneal congestion also. Okay, so never forget to check the corneal sedation, which is very, very important. So next we'll see next case. So this is a case, usually we get a history like 18-year-old boy, defective vision, which is very progressive and painless. You may get a history like frequent change of glasses and symptoms of allergy. So what is the most probable diagnosis? Yes, definitely. So these are the usual signs of the patient, and you have to specifically look for these signs. So this is a usual clinical presentation. So patient usually present with blurring of vision, monocular diplopia, glare, halos, and you may specifically ask for any contact lens wear, family history of ectopy, and past history of any surgeries or previous scans. Okay, so these are the usual signs. So you don't forget to look these signs like steepening of the cornea, any thinning, scarring, and other particular signs which is very specific, as you know, Fleischer ring, Vaux striae, increased visibility of corneal rings, any ruptures in the Descemet's membrane, all these signs. And you may get other features like some other disorders like corneal disorders and non-corneal disorder which are all associated with keratoconus. So you may also look for these signs also. Okay. So you may get some systemic associations also. So you may ask the question or you may get any systemic signs of these syndromes also. So don't forget to look these. So another case, this is a 60-year-old patient present with a history of pain, redness, watering and defective vision, and history of cataract surgery in the past. So what is the most probable diagnosis? PBK or pseudophakic bullous keratopathy. So these are the different causes of corneal edema, and what all things you will like when you get a case of corneal edema. So particularly in a case of PBK, you have to look for these signs. So edema, you have to mention the location, the extent, the degree of edema, and look for the other signs, particularly the epithelial defect, microcyst, bullae, stromal haze, endothelial folds, vascularization, and whether there is any increased corneal thickness. So localized edema, what are the most common causes? You may get in Descemet's membrane detachment, instrument touch, vitreous weak, or herpetic keratitis. So any limbus to limbus edema, always think of TAS or toxic anterior segment syndrome. So other, apart from cornea, what are the other signs you have to look? So you have to look for the shape of the cornea, any peaking. So look for the presence of the vitreous. Pupil may get dilated due to any previous iris damage. So patchy iris atrophy, always think of segmental iris atrophy, always think of a viral etiology. So anterior chamber reaction you have to mention, and specifically you have to look for these, any vitreous strands in the AC, any retained lens matter, keratic precipitates, IOL. And in the IOL, you have to see whether any malposition of the IOL, any deposits in the IOL, and also don't forget to check the intraocular pressure. Okay. So you may get a question on vascularization. So it is very important. You have to differentiate the superficial and deep vascularization. So you may get questions on dystrophy and degeneration, how to differentiate these. So 65-year-old, this is another case. Defective vision and history of cornea transplant surgery. So what is the most probable diagnosis? Failure. Yeah, so graft rejection, not failure. So you have to differentiate between rejection and failure. I will be dealing that, just a single slide. So what are the common symptoms? You may get pain, redness, photophobia and vision. So when you get a case of graft rejection, what all signs you have to check? So it is very important to check the circumcorneal congestion. Sometimes you get congestion without any other corneal or any other signs. So you have to look for any raised epithelial line, that is the epithelial rejection line, corneal haze, stromal infiltrate. If there is any keratic precipitates, look for the number, location, identify the old, whether it is new. look for AC reaction and Kodados line, which is very important. That is a endothelial rejection line. So don't forget to look the graft Holt junction. So you have to mention the suture, whether it is interrupted or continuous. Mention any loose suture, protruding nodes, any infiltrate, vascularization, and look for the quadrants. So how will you differentiate a sterile and infectious infiltrate? This is also very important. So primary and graft rejection, I am not going to the details. So this is the last case. So this is case of anterior uveitis. So how will you appraise? Usually patient present with pain and photophobia, redness and blurred vision. So usually acute onset, you will go to a diagnosis of acute anterior uveitis. So sometimes symptoms may not be present. Patient present with a blurred vision, usually chronic. And pain, photophobia, blurring of vision with a period of inactivity of more than 3 months of medication, you will get a chronic recurrent anterior uveitis. So ocular history, very, very important. Mention all these features. So systemic history, which is very, very important in uveitis, joint pain, fever, cough, weight loss, oral genitourinary ulcers, skin lesions, drug intake, all these history is very, very important. Systemic evaluation. So examination is also very, very important. Lid and adnexa, I have to mention all these. Conjunctiva, cornea. So cornea I am already told, but specifically you have to see the size, the morphology and the distribution of keratic precipitates. Like Fuchs, you will get entirely distributed all over the endothelium, stellate KPs, herpetic disease. So keratic precipitates, so please see whether it is old or new, whether it is granulomatous or non-granulomatous. Anterior chamber, you have to mention the AC reaction. Also look for other signs like hypopyon, hyphema, iris, broad-based, persistent posterior synechiae. Always think of tuberculosis, tent-shaped anterior synechiae, ocular sarcoid. So nodules, as you all know, look for these signs. So iris atrophy, any transillumination defects in the iris. Lens, look for the cataract, inflammatory membrane or any pigments of the anterior lens capsule. And gonioscopy, which is also very, very important. So hypopyon, whether it is mobile, usually we think of Behcet. Immobile, which is HLA associated. So these are all you know, I think, the features of granulomatous and non-granulomatous. So investigations, recurrent, severe, all these cases, you have to investigate a patient. So provisional diagnosis is very important. You have to mention the diagnosis, laterality, chronicity, significant associated features. Mention the differential diagnosis, investigations and treatment. So any case, don't forget to draw the diagram, corneal diagram, which is very, very important. So these are the color code which is used for the corneal diagram. Okay, so any anterior segment case, you may get a question on slit lamp. So please study this also. So I wish all the best for next we